Everybody. So I'll be speaking on what is the best injection for me. So the agents that we're going to talk about and consider are the standard of care right now, which is Accentrix, previously known as Lucentis, Avastin. The new players in the market, Eylea and Razumab, which is a biosimilar like ranibizumab. The steroid substitutes, which Gopal has just talked about Ozurdex and Tricot. So this is what we have with us. Now these key anti-VEGF agents, of course, they come from different companies. Their molecular characteristics differ. All of them attack VEGF-A, block VEGF-A. Efficacy also blocks VEGF-B and platelet growth factors. Bevacizumab is a Fc-containing antibody. So is Efficacy, with the difference that it's a soluble fusion protein. And their intravitreal eliminations also differ. 2.8 days for ranibizumab, 4.3 for bevacizumab, 4.79 days for Efficacy. Systemic half-life elimination 2 hours for ranibizumab, 20 days for bevacizumab, 5-6 days for Efficacy. Potency inhibitory 0.06 for ranibizumab, 0.66 for bevacizumab, 0.68 Efficacy. Now these have some bearings on what we're going to talk about. So the intravitreal VEGF injection and the systemic VEGF suppression also has to be kept in mind, especially when you're dealing with those very high-risk patients. Normal adult plasma VEGF levels is just 0.1 nanogram per ml, and Lucentis or ranibizumab has a systemic T-half elimination. I mean, it's in the bloodstream for half a day, whereas Avastin is 21 days odd, so that much longer. Plasma levels doesn't go beyond 2.5 nanograms per ml, so the systemic suppression can be expected to be much lesser, whereas it's about 300 times that for Avastin, which is why the natural concerns for systemic issues. So in taking the therapeutic option, one must keep in mind, of course, efficacy, which we all just talked about right now, but also importantly is safety and cost, which is a real factor in our scenario. So safety issues, first of all, what we must understand is that ophthalmic trials are not really powered to assess safety issues. The sample size is just not large enough. Most of the trials are 600, 800 cases, 1,000 cases. To really look at safety, you need about 20,000 cases, which unfortunately doesn't happen in ophthalmology. The SAEs noted in ophthalmic trials are not really seen in systemic trials. And the SAEs with the PRN, lesser dosing, is not seen with the monthly dosing. So there's a lot of randomness in the SAEs which are being reported, and one should be careful about considering these. Now just look at some of the safety issues that came from some of the major studies. CAT, ranibizumab versus bevacizumab, rates of death and AT events were almost similar for both groups. Proportion of patients, one or more systemic serious SAEs was higher with bevacizumab than ranibizumab, but most of these excess events were not previously associated with systemic therapy. So just to show you that sometimes you have to take this and read between the lines. Equivalence of safety issues was corroborated by the Cochrane meta-analysis, which happened recently. Protocol T for DME, looking at the 3 drugs. This is one major one where we have the 3 drugs put together. Rates of deaths, SAEs, hospitalization, pre-specified SAEs were similar in these 3 treatment groups. And no significant difference with respect to all these events was noted. Infectious endophthalmitis, as you can see, the rates are almost similar. For Maxigen Lucentis, it is a cumulative rate, that's why it looks higher, but generally it's more or less the same for all. Now, situations where Avastin I would avoid is, you can look at statistics, so finally you have to treat that patient sitting in front of you. So a patient with uncontrolled hypertension, recent myocardial infarction, recent strokes, cerebrovascular accidents, I might perhaps not favor Avastin, and allergies. There is also this issue about Avastin potency, which we need to understand when you look at trials and then look at the practice that we have. Avastin used in both the DRCR and CAT trials, which are great trials, were in pre-filled glass syringes which came directly from Genentech. The process of compounding and storing Avastin in plastic syringe may introduce a high variability in stability and potency, so says Januzzi et al. But Bakri et al. In a previous study showed that Avastin in plastic tubercular syringe stored at 4 degrees centigrade, which is the door of your fridge, is stable for 6 months. So there's a little bit of confusion and a little bit of gray area out here. Now the cost factor is important. Accentrix about 18,000 to 30,000. Eylea, we now heard that is almost about 50,000. Avastin 5 to 10,000, 15,000, and Tricot much lesser. So these issues are there, and these will always play a role in us when we decide, when the penny decides your pill. So efficacy generally, efficacy equivalence about 90%. That's my ballpark figure. Now, Dr. Shroff has already gone over a lot of the studies. I'm just going to point out to you this Cochrane systematic review which looked at bevacizumab versus ranibizumab and found no important difference in effectiveness or safety between these two, but there was a large cost difference. A recent one, just cutting edge stuff, aflibercept neovascular AMD from the Cochrane database shows it looked at aflibercept juxtaposed against ranibizumab, bevacizumab, and found that there was comparative effectiveness with aflibercept and ranibizumab. And current information also shows that the safety profile is also similar. Another systemic meta-analysis which came out shows the superiority remained unclear between ranibizumab and bevacizumab, and intravitreal aflibercept is also equally efficacious but had far fewer doses. So there's lesser dosing there. Another article which looks at basically aflibercept for refractory neovascular AMD, refractory to bevacizumab and ranibizumab over 1066 eyes, shows that switching from bevacizumab to ranibizumab to aflibercept can improve equity. So that's something again you must keep in mind. Now the VIEW studies, when one looks at in toto, at the 96 week results, all aflibercept and ranibizumab more or less equally effective in equity. Okay, but one must remember that they were a little heterogeneous. The VIEW 1, which was mainly done in the Western populations, showed aflibercept gaining plus 2.8 letters compared to ranibizumab. But VIEW 2, which was done in India and Asia, and we were part of that, I was an investigator there, actually the opposite happened. Ranibizumab did better than aflibercept, although marginally. So this can happen depending on what population you come from. And a small case series put out by Patel et al. Shows that aflibercept showed an impressive, rapid, dramatic response of the RPEDs to intravitreal aflibercept in patients who were refractory to bevacizumab and ranibizumab. That's impressive, and this many people over the world have also corroborated it. Now, a path survey which came out from Stone et al. Showed that if Avastin, Lucentis, and Eylea were to cost the same, choice of treatment for new onset neovascular AMD shows that the trend in US is that there seems to be a greater number of people migrating to first choice Eylea in the States. So for me, primary treatment, if a patient can afford, then I would Lucentis or aflibercept. For me, the cost makes a difference here because there's going to be multiple dosing. So if two drugs are equivalent, then I'd probably go for the cheaper drug, and in this case it is ranibizumab. If you cannot afford, then either of them, then Avastin. Refractory cases, there is impressive evidence towards aflibercept, and for large PDs with good vision, with those kind of cases where you wonder whether we should treat it or not with a bit of hemorrhage around that, perhaps aflibercept might now be a good option to try out. Coming to DME, again Gopal has talked a lot about it. Mahesh has. So from the trials, there's a lot of impressive evidence for ranibizumab. DRCR3, which has looked at these three, showed that there was higher efficacy for aflibercept over ranibizumab, bevacizumab in the poorer vision group. That is less than 20 by 50. In the 20 by 50 to 20 by 20, the good vision group, all three were more or less similar. There's not much to choose on. Separate them. Bevacizumab, one thing, definitely reduced macular thickness the least. Dexamethasone, Gopal has just talked about that. I think its USP is one clear place is post-vitrectomized eyes, where the study has shown impressive gains in acuity and reduction in macular edema. The MEAD study showed that it can improve acuity in patients who were previously treated with laser or other pharmacotherapies. So that's another area where it can be used. This issue about IVT and Avastin has always been there, and we've had mixed results with that. I've not been very impressed with this. Sohailan and Wang have kind of corroborated that thinking, and they showed that adding IVTA to Avastin offers no real significant advantage in DME cases. So for me, DME management, poor vision, aflibercept as and when it comes might be the first scientific choice. Of course, patient has to be able to afford that. Good vision, all three is any of the three is fine. Refractory DME, if what we usually patients on Avastin, we have moved them over to Accentrix or vice versa. Now again, aflibercept is a choice for us. Elderly pseudofakes, IVT is an option because the IOP rise issues are not there with the elderly as much as with the younger patients. Ozurdex I mentioned for vitrectomized patients. Diffuse DME, one can still consider combination treatment. If you are using Accentrix or ranibizumab, you might want to defer the laser as in DRCR protocol I. Again, laser still stands for non-center involving DME. Now, retinal vascular occlusions, Abhishek has talked a lot about it. I'll just say that for ischemic CRVO, this was one little impressive thing which stood out for me. The aflibercept-based trials, Galileo Copernicus, include a far higher percentage of these cases compared to ranibizumab in the CRU study, which was just 0.5%. Also, the average duration of the cases was much more in the aflibercept studies, which averaged 9 months, whereas it was 3 months more recent. So, for chronic cases and for ischemic CRVO cases, perhaps aflibercept can be tried. Also, in these cases, patients were included with afferent pupillary defects, which was ruled out in CRUs. And 6-month gains were a little more, in spite of all that, with aflibercept than with CRUs. But again, it's not wise to compare trials. The Comrade also showed impressive gains for ranibizumab, for both CRVO and BRVO. So this particular meta-analysis shows that case of BRVO did much better with Avastin than IVTA. So in CRVO, for me, non-ischemic CRVO, all are fine. Or any of these are fine. Ranibizumab has a lot of evidence going for it. Aflibercept is coming out with great stuff. Ischemic CRVOs, evidence that perhaps now, if the patient can afford, you can try aflibercept first. BRVO, again, all three are fine. IOP rise, because of those issues, I would always tend to put steroids on the back burner. Polypoidal choroidal vasculopathy, the EVEREST gave us great guidelines in favor of combination therapy PDT with 3 loading doses of ranibizumab. And even when they regress and there is a leakage on FA, but there's a regression of polyps on the ICG, you can still retreat with ranibizumab. The EVEREST had very clear guidelines there. But a larger study, interestingly, laptop study, went totally against that and showed that 3 IV Lucentis or ranibizumab is better than PDT. And the gains were far more impressive. So the jury is still out there. And Avastin Vs Lucentis showed that both had bevacizumab and ranibizumab had similar effects in acuity and macular edema regression and regression of polyps as such. A CYTO study showed that again for refractory cases, aflibercept seemed to do well, cases refractory to ranibizumab. So that's an area. So in primary treatment combination, you can try PDT with ranibizumab or bevacizumab, patient cannot afford. Monotherapy, ranibizumab or bevacizumab. Refractory treatment, PDT with or combination if polyps are present, and if they're not really there, then perhaps you can even consider aflibercept. Myopic CNVMs, a meta-analysis by Wang and Chen, showed that the acuity gains were similar for bevacizumab and ranibizumab. That line doesn't swing either way, so it shows it goes right down the center, which shows equivalent efficacy. And so there's a lot of evidence for ranibizumab from the Radiance, Brilliance and the repair studies. But again, when there's, for me, non-AMD CNVMs, I would probably first go with bevacizumab, possibly. Refractory cases, aflibercept, the mirror study has shown impressive results. Non-AMD CNVMs like IGT, angiostreak CNVMs, again, those kind of cases, there's only anecdotal large case series. I would use Avastin. Preferably, if the patient can afford, of course, they can always go with ranibizumab. Uveitic CNV is one place, if there's activity, I might go with a combination of IVTA and bevacizumab. Neovascularization iris, intravitreal bevacizumab, because this is like a temporal kind of thing. You just want to gain that before you put in the more permanent laser. And we've done this for pre-trab cases, pre-laser cases, pre-vitrectomy cases, and you can see the impressive results with Avastin. PDR cases, refractory to laser, once laser is put in, still it's not there, then I would rather give bevacizumab. Of course, DRCR protocol SS, a big shot in the arm for repeated Lucentis treatment. But for me, I think in Indian scenario, probably it's not very applicable. And other scenarios are vitreous hemorrhage with active bleeds, with macular traction detachment with active new vessels, not just any odd macular traction. If there are active new vessels and you're going to operate them, then you can give pre-op Avastin and within 3 days take up for vitrectomy. The other 2 options, ranibizumab, and this is just too expensive for that. It's almost doubles the cost of the surgery. For ROP, BEACH has shown us anti-VEGF therapy is useful, bevacizumab. Or if the child is a little at risk, probably safer to use ranibizumab because of the systemic issues which I mentioned. APROP is one place where a lot of people are using anti-VEGF. The Rainbow study is ongoing and we'll have interesting results coming. So in conclusion, evidence-based practice is definitely essential, but one must always remember that comparing drugs across trials is unadvisable because there are different baseline criteria, different patient characteristics, different methodologies, different endpoints. So don't just look just at the conclusion, see whether the trials can actually be compared. Thank you.